Can you see my screen?
Yes.
Excellent. And can you hear me clearly?
Perfectly, yeah.
Good. Okay, I have been having some glitches with my internet connection, so if at any point it starts to drop off or anything, just let me know, okay?
Okay.
Welcome, everyone. So it's my pleasure to speak with you today about the assessment and management of seizures in cardiac patients. So over today's talk, you'll hopefully by the end of the talk learn to recognize which critically ill infants and children in the cardiac ICU are at greatest risk for seizures, identify some common seizure types, and be familiar with the diagnostic workup and the management of seizures, and appreciate the role of continuous EEG for the assessment of seizures in the ICU. I'm going to begin with a few videos just to set the stage here. Just a minute. This was working before, so let's hope it works again. Yes. So this is a 2-day-old neonate with congenital heart disease. You can see quite sick, ventilated, and you notice some unusual movements. We're going to come back to this. I'm going to show the video one more time. Okay. Are you able to see the video?
Yes, we can.
Is it playing? Is it playing smoothly enough that you can actually see it?
Yeah.
Good. Okay. So I hope you all saw that there was some twitching movement there of the right foot, and we'll talk about what that means. Just in a second, I'm going to close my door. So is it a seizure? Is it not a seizure? How do we decide? Food for thought. Okay, let's look at the next video. Whoops. Next video. All right. Yeah. One-month-old baby in your ICU, post-op, weaning off of morphine. Cecilia, are we able to do anything interactive here, or is this not an interactive? Is it too difficult?
Yes, they can turn their mics on.
Yeah. So I'd be interested if anyone is bold enough to tell me what they think this is and how would they describe this movement. It's not a trick question. Maybe something you've seen before. Any takers?
So someone's typed in the chat abstinence or absence. Abstinence is what was written.
Abstinence. Okay, interesting. Yeah. And what about the movement itself? How would you describe what the movement looks like?
Cycling movement.
Sorry, I couldn't hear that.
Cycling movement.
Say it again.
Cycling movement.
Cycling. Okay, interesting. Any other thoughts?
It could be seizure or jitters for withdrawal of morphine.
Okay, jitters. Yeah, jitters is a term I've heard before. Cycling is another type of movement. We can talk about what that looks like. And what do you think the caregiver is doing there?
He's trying to see if it could be seizure or regular movement. If it stops, it's not a seizure, but if it doesn't stop, it is a seizure.
Yeah. So they're trying to suppress the movement by gently restraining the arm or the limb to see if the movement goes away. And what do you think? Do you think it's suppressible? Maybe.
Yes.
Okay. All right. Okay, we'll come back to it. And this is the last example. Oh. See if we can get this to work. Okay, here you're going to have to look really carefully. This is pretty subtle. See what you can see. If you see anything abnormal, you speak up.
Baby is connected for the EEG.
Baby's connected to an EEG. Yes, all of these babies are connected to EEG because I'm going to show you what the EEG showed in a minute. Any abnormal movement here?
Yeah, the right shoulder is twitching.
Yeah.
Mhm. Yeah, interesting, huh? Could that be a seizure?
Yes.
Okay, any other thoughts? Do you notice, is it changing at all, that movement? Maybe
It's
becoming
pretty
a little.
consistent.
Okay, now watch, they're going to try and do the same thing and hold it down. Doesn't look like it's suppressible, right?
Yeah.
It's also starting to involve more of the arm, so becoming a bit larger in amplitude. It's quite rhythmic too. I think you'll agree. It has a real sort of rhythm, maybe one little movement every second or so. Okay. So all three of these babies had these concerning movements of different kinds. And, the question is, are these seizures? Are they not seizures? What does it mean? So hopefully by the end of the talk, you'll be able to answer these questions. We'll do it together. So why should cardiac nurses care about the brain, right? You're more concerned with the heart. Well, we know that neurologic outcomes are really altered by cardiac anomalies in surgery. And we know that the brain perfusion is very dependent on the heart, obviously, under the type of anomaly versus cyanotic versus non-cyanotic. So cyanotic being more potentially harmful for the brain. Cardiac bypass can be risky, especially if it's prolonged. The longer the duration of bypass, the more potential risk there is to the brain. ECMO itself is obviously a life-saving therapy. So, but it is also associated with significant risk to the brain, both from hemorrhage and from stroke. And seizures often happen in babies with brain injury in the context of congenital heart disease. So seizures are common among certain critically ill children. We'll talk about which ones are at risk. They may actually contribute to brain injury. And this is somewhat controversial, but we think that prolonged seizures certainly are not good for the brain, and they might actually be making underlying brain injury worse. Importantly, seizures are treatable and preventable, so we can easily stop most seizures with medications. Seizures can be convulsive or non-convulsive, and I'll show you that the majority of seizures in the ICU are actually non-convulsive. In coma, or altered mental status, is the defining characteristic of non-convulsive seizures. And that's a big diagnostic challenge in the ICU setting because there are many other potential causes of altered mental status besides seizures. So how do you tell if a patient's altered mental status is due to seizures or due to sedation or due to the underlying brain injury? Here are the most common causes of seizures in the cardiac ICU. Stroke, so ischemic brain injury, usually due to embolic causes, for example, a clot in the heart, a thrombus that travels to the brain. Cardiac arrest, causing brain injury and seizures as a secondary response to brain injury, anoxic brain injury. Meningitis or encephalitis sometimes occurs even in the cardiac side of the ICU. And brain malformations. So some children with heart malformations also have brain malformations. After surgery, here are the main risk factors. So certain types of congenital heart lesions are known to be associated with higher seizure risk. hypoplastic left heart and BSDs, longer circulatory arrest, lower preoperative pH and space deficit, and an underlying genetic condition, because those are also more commonly associated with brain malformations. ICU seizures are a real diagnostic challenge. This is a study done in a very experienced ICU, a neonatal ICU in Ireland, where they monitored 51 babies with continuous video EEG. But they didn't actually read the EEG in real time. They just monitored the children, and then after the fact, they looked at the EEGs and the videos and diagnosed the seizures based on that. It turns out there was a big problem of under and overdiagnosis of seizures. So only a third of the EEG seizures actually had signs on the video that you could see. And only 9% of the seizures that were confirmed on EEG were actually recognized at the time by bedside staff. So 1 in 10 of the EEG confirmed seizures. So pretty dismal. The flip side was that overdiagnosis of seizures was common. So only 27% of clinically suspected seizures actually turned out to be EEG confirmed. And lots of anti-epileptic meds were being given to treat things that turned out not to be seizures at all. So we have this big problem with underdiagnosis and overdiagnosis of seizures based solely on the clinical assessment. We think of seizures in different categories. There's clinical seizures that you can see with your eyes. They can take various forms, which we'll talk about. And then there's electrographic seizures, which we can detect on the EEG. You'll notice the red circle is bigger and they only partially overlap. Where they overlap is called electroclinical seizures. And then there's this large group of subclinical, non-convulsive, other terms are silent or occult seizures that make up the majority of seizures in the ICU setting. There are clinical only seizures that are also thought to be epileptic. They may be coming from a deep focus in the brain that can't be detected by the scalp EEG, but these are extremely rare. And I wouldn't worry too much about these. Typically, they are associated with apnea, for example, without any kind of convulsion. And it's our job to detect these. But these are a tiny wedge, a tiny sliver of the overall seizures that you see. Much more commonly is to see a seizure on EEG with no clinical correlate. So how does this happen? Seizures are generated in the cortex, and the abnormal brain activity, hyperactive brain activity, gets propagated down through the corticospinal tract, brainstem, spinal cord, into your nerves and muscles. And that's the normal sort of cause of convulsion. When we treat seizures with benzodiazepines or barbiturates, those target the cortex, the brain, and shut down abnormal brain activity. But these drugs also act elsewhere. They also act in the brainstem, they also act in the spinal cord, and that may account for this phenomenon of uncoupling that we see, which is when seizures initially are electroclinical, and then following treatment, you cure the clinical part of the seizure, but if you have an EEG running, you'll notice that the seizures are actually still going on in the brain, and you've just blocked their expression clinically. So what are the most common clinical expressions of seizures? The most definitive, I would say, is a focal clonic movement. It can be in one location, so focal. It can be multifocal from various different parts of the body. They can alternate one side to the other, migrate. You can have hemiconvulsive seizures involving a whole half of the body. You can actually have seizures involving the trunk or the abdomen or the neck. You can also have tonic seizures, which is a sustained stiffening of an arm or a leg. Usually it's focal. Myoclonic seizures, which are a short lightning-like jerk, and spasms, which are a little more of a sustained contraction, almost like a brief tonic seizure. And then there are these subclinical seizures, which we talked about, non-convulsive, occult, silent, electrographic, they all mean the same thing. And these happen either, and these are due to uncoupling between electrical activity and clinical activity, which can happen spontaneously, but more commonly happens due to anticonvulsant therapy or paralysis. Obviously, if you have a paralyzed patient, you're not going to see any clinical expression. But there's lots of other activity that may be mistaken for seizures. Eye deviation that's intermittent or unsustained, sucking movements, myoclonic jerks. Some of these bicycling movements that we know are sometimes seizures are often actually not seizures. And so there's a whole repertoire of different types of behaviors that may or may not represent seizures. And the only way to know for sure is to get an EEG, to capture them on an EEG. So how do we actually do that? So EEG is a technique that measures cortical brain activity. So it's very similar to ECG, except the electrodes are on the brain or on the scalp instead of on the chest. And the voltage coming from the brain is about 1,000 times lower than the voltage generated by the heart. So these are tiny, tiny voltages. And you need a special amplifier to actually pick that up. Oops. I need a special amplifier here. I'm going to actually change my pointer here so you can see there. I think you should be able to see the pointer now. You need a special amplifier to be able to pick that up and to filter out all the other noise in the environment, including the noise from the ECG. So a conventional EEG uses 8 to 19 scalp electrodes. Usually they're placed like this with either paste, or sometimes when they're glued on for longer periods of time, we use something called collodion, which is a non-toxic adhesive. And I would say over the last decade or so, there's really been a paradigm shift. Obviously in the ICU, from an emphasis on survival to outcome, especially neurodevelopmental outcome, and a paradigm shift in how we use EEG. So this is what EEG machines used to look like about 20 years ago. They were analog paper-based devices with pens, and now they look like this. So these are the ultra-portable devices that can be rolled to the bedside, and they have a video camera, right? And it's all digital-based, and we can actually review this data remotely as well. And there's been a paradigm shift in how we use EEG. It used to be a diagnostic tool where the technologist would come to the bedside and do a 30-minute recording, take it up to the lab, and we'd look at it at some point, maybe the next day. But now it's a monitoring tool with continuous recordings, with video, and the possibility, at least, of real-time interpretation. So in 2008, at SickKids, we developed some guidelines, some indications for which babies or which children in the ICU deserve consideration for EEG monitoring. And I'll just show them briefly to you. Many of these are a little more common in the pediatric ICU, the medical surgical side, rather than the cardiac side. But we monitor patients who are actively seizing to help us guide therapy, because as I said, unless you have an EEG, you won't know necessarily if you've successfully treated both clinical and electrographic seizures. Patients who have encephalopathy meaning altered mental status, who are at risk for seizures, maybe because of a brain injury, patients who are paralyzed, who have a risk for brain injury, patients who are having unusual movements that you want to characterize that might represent seizures but might not. And then in the neonatal ICU, you may have seen, if you ever worked in the neonatal ICU, there's a technique called amplitude integrated EEG, which I'm going to show you pictures of. And this is a bedside monitoring technique that is a simplification of EEG that sometimes can help you assess for seizures at the bedside. And some of that is now being done at SickKids in the cardiac ICU. So how do you decide if you need an EEG? This is what we teach our residents. So is the patient at risk? And I'm going to show you some of the risk factors in a minute. Is the patient at risk for seizures? Does the patient have a history of convulsive seizures? That's a risk factor. And does the patient have some risk for acute brain injury? But that's not enough, because if you can assess a patient clinically, especially an older patient, if they're talking to you, if they're responding, it's unlikely they're experiencing seizures. But if your clinical assessment is compromised in any way, if the patient's obtunded, if the patient's comatose, sedated, or if they're paralyzed, you have no way of knowing clinically if a patient's seizing or not. And that's where the EEG can be really helpful. So how common are seizures really in the ICU setting? This slide illustrates, it's a summary of lots of studies from an ICU setting in children, and it shows you the prevalence of seizures in black and status epilepticus, which means continuous or intermittent seizures lasting more than 30 minutes. You can see overall the mean prevalence was 34% and 14% for status epilepticus. Now, these were patients where there was some suspicion that they might be at risk for seizures. This wasn't every patient in the ICU being monitored. So you don't need to worry that a third of the patients in the ICU were having seizures. I don't think that's the case. But among children where people thought, hey, maybe this child's at risk, it turns out that 30% of the time they actually found seizures. So it's a pretty high yield for a test like this. The majority of seizures are subclinical, as I've said before. So when you look at how many seizures are actually visible, even on video after the fact, only 20 to 40% have any kind of expression. And actually most of those are so subtle that you're not going to recognize them. Even if you're right at the bedside, you're caring for the baby or the child, often you won't realize that they're having a seizure because it's so subtle. Look and you shall find. So how long do you actually need to monitor for seizures? This is actually an important question because it affects how we allocate resources, right? EEG monitoring is very time consuming, expensive. Do we need to monitor indefinitely? How do you know? And what's the advantage of monitoring over just a half an hour or an hour EEG? So this illustrates the time to the first seizure. There's the percentage of patients that had their first seizure detected who underwent prolonged EEG monitoring. You can see that 4 or 6% of seizures, the blue is convulsive and non-convulsive, and the gray is non-convulsive only. So very few patients had seizures right at the beginning, but by the first hour, you picked up about 50% of patients who were destined to have seizures. And within 24 hours, we're getting up to 80 or 90%. Okay, and then you have diminishing returns here. If you monitor for another 24 hours and another 24 hours, you're only getting a handful of additional patients who have new onset seizures. So based on data like this, we know that 80 to 90% of seizures begin within the first 24 hours of monitoring. You need about 3 times the length of recording to capture the remaining 20%. So we actually stop recording after 24 hours if we haven't detected a seizure, because we know that chances are pretty slim that you're going to seize after that point. And we're trying to balance the, giving EEG resources to those who need it the most. This is a classic paper from the group at Children's Hospital in Philadelphia, who did EEG monitoring patients and children after cardiac arrest. And this was in the era when cardiac arrest hypothermia trials were going on. Hypothermia has fallen out of favor now for cardiac arrest. But at this point, babies or children were treated with hypothermia and then rewarmed. Hypothermia for 24 hours, rewarming for 24 hours. And it turns out almost half of these patients actually had seizures on their EEG, and about a third of them had status epilepticus. You can see this nice illustration of the seizures over time. So this is about 24 hours of hypothermia, 24 hours of rewarming, and then 24 hours of normothermia. Each of these lines is a patient, and the blue sections are seizures, the red sections are status epilepticus. So you can see about half the patients had seizures, and most of them started within the first 24 hours. Okay, here's the first 24-hour mark here, but there were actually several who started having their seizures during rewarming. And so based on these data, we actually will sometimes continue monitoring for about 72 hours in patients with cardiac arrest, certainly if they're undergoing hypothermia, because rewarming, so hypothermia itself appears to have a neuroprotective or an anti-epileptic effect. And then when you rewarm patients, they can have rebound seizures. So this really nice study looked at an experience again from Children's Hospital of Philadelphia, where they actually just implemented EEG monitoring in every baby undergoing cardiac surgery. So every neonatal cardiac surgery over the period of about 18 months. So 172 babies, a high volume center. And when they were very permissive, they monitored every child, only 8% of them actually had seizures. So much lower than some of the data I showed you before, because presumably because they monitored everyone, okay? So the median time to the first seizure was 20 hours after return to the ICU from surgery. So this is all post-op cases. Most of them were EEG only or subclinical, non-convulsive, 85%. And those who had seizures often had a really high seizure burden. Status epilepticus occurred in 62% of the 8% of patients with seizures. These were the predictors of seizures: delayed sternal closure, longer hypothermic circulatory arrest time. And they showed that mortality was indeed higher among those with seizures than those without. Does that mean that the seizures caused higher mortality? We don't know, because it could be that the babies were just sicker to begin with, and the seizures were just a symptom of the illness. But they certainly are a worrisome sign, and they may contribute to injury. Seizures are also fairly common during ECMO therapy. And so in a couple of sites that have been doing ECMO therapy with continuous EEG, they found a prevalence of about 17 to 23% of EEG confirmed seizures. Most are subclinical. Here are some risk factors for seizures during ECMO. So low cardiac output or platelet count prior to ECMO, low pH prior to ECMO. And if the neuroimaging showed any kind of edema, that was also a risk factor. And not surprisingly, in these children who had seizures, the outcomes were worse. Seizures were associated with, again, edema on imaging, brain injury, and reduced survival. Again, we don't know if it's chicken or egg. We don't know if the seizures are just a symptom of the worsening brain injury that leads to the worse outcome, or if the seizures themselves are actually contributing to the worse outcome. We have reason to believe they do, and I'm going to show you some data for that. So we know that brain injury can lead to disability. We know that brain injury can lead to seizures. So is there this secondary injury pathway between seizures and disability as well? There's certainly plausible mechanisms for this. So we know that increased brain activity, if it's hyperactive, can cause excitotoxicity. It's almost like it's burning out the light bulb in the brain. And hypoxia ischemia can also occur. Imagine if you have a part of the brain which has a very tenuous blood supply. Maybe there's just been a stroke. There's a partially clogged blood vessel, or there's an area around a stroke where there's tenuous blood supply. If you superimpose a seizure on that with a very high metabolic demand, you could tip someone over the edge and cause brain injury in the so-called penumbra around the ischemic brain injury. So what's the evidence for seizure-associated brain injury? I'm just going to show you a couple of studies. One that you may have heard about, this is the Boston circulatory arrest study, a very famous study that initially was just looking at the what type of anesthesia was better for children. So they randomized patients with transposition of the great arteries to either low flow bypass versus deep hypothermic circulatory arrest. They happened to do an EEG during these patients, and again, the EEG was not being looked at. They just did it as part of their data collection. Nobody was recording. They were recording the data, but they weren't analyzing it in real time. It turns out about 20% of these patients in the trial developed seizures. These were untreated seizures because they were EEG only, most of them. And when they did their follow-up studies, it turns out that the seizures were actually the most consistently, the medical variable most consistently related to outcomes, all the way to 16 years follow-up. So seizures clearly are a marker of risk for worse outcomes. This is a similar study from Children's Hospital of Philadelphia. Again, infants and neonates who underwent complex heart disease surgery. They did 48 hours of CEG monitoring, continuous EEG. This time, though, they actually looked at the EEG and they responded to the presence of seizures. And their seizure prevalence was a little bit lower, 11%. And when they evaluated these children at 1 year, seizures were not predictive of a worse Bayley score. At 4 years, they were associated with worse executive function, but not worse cognition, language, and attention. So we're left with this question: seizures. Should we be treating them? Should we not be treating them? there's certainly arguments to be made on both sides. So on the one hand, if there is a risk for secondary brain injury, maybe we can reduce it with commonly available and safe medications. Maybe we can improve neurological outcome and reduce the chances that these children go on to develop epilepsy, which can occur with untreated seizures. On the other hand, treatments that we have for seizures are usually sedating. If you have to escalate therapy, you might cause hemodynamic instability. And there's some concerns about neurotoxicity of certain medications, but I think in my opinion, under the doses we're using, that's probably not a big concern. So let's talk a little bit about drug therapy for seizures. So here's some medications you will have seen that are used for the treatment of acute seizures. And phenobarbital, phenytoin, or phosphenotoin are the most commonly used loading medications in the ICU setting. In cardiac patients, often phenytoin is preferred over phenobarbital because of less hemodynamic instability. But if there's any cardiac conduction abnormality, phenytoin may not be so popular because it is arrhythmogenic. I'll talk a little bit about phosphenotoin in a minute. Phosphenotoin is a water-soluble prodrug of phenytoin and has certain advantages to phenytoin. Lorazepam and diazepam are our first-line medications for stopping acute seizures. They're benzodiazepines, short-acting, if you want to stop a seizure quickly, those are your best bet. So initial treatment algorithm often involves the use of lorazepam initially, followed by a load of either phenobarbital or phosphenotoin, usually 20 milligrams per kilogram. And then if those fail, you're on to usually a midazolam infusion. And at that point, you really should be considering doing an EEG because for the reasons I shared before. So you often cause uncoupling between the clinical and electrographic seizures. And you may think you've stopped a patient's seizures, but if you do an EEG, you'll notice they may still be seizing. Phosphenotoin versus phenytoin, brief table here. I don't know how many of you actually have access to phosphenotoin. Many hospitals are a bit reluctant to stock it because it is a little bit more expensive than phenytoin, but the price really isn't that different. And there are some advantages. So first of all, I mentioned it's water soluble versus phenytoin is dissolved in propylene glycol, which is antifreeze, has a pH of 12. You can infuse phosphenotoin more quickly. You can actually even give it IM if you don't have an IV access, which is usually not an issue in the ICU. But more importantly, you can give it in any IV solution. You don't have to worry about whether there's dextrose or not in your solution. Whereas with phenytoin, you have to be very careful to not give it in a dextrose-containing solution because it will precipitate. And so you need to use an inline filter. That's part of the infusion protocol for phenytoin to protect the patient from inadvertent precipitation of dextrose-containing solutions. Both drugs can cause cardiac arrhythmias, but phenytoin seems to be a little higher risk probably because of the propylene glycol actually, because the active agent is the same. So phosphenotoin gets converted rapidly to phenytoin in the bloodstream in about 5 minutes. So although you can infuse it faster, it takes about 5 minutes to become active. And so the differences start to become less obvious when you look at time to action. One important reason why phosphenotoin has become the drug of choice in the US especially is this purple glove syndrome. I don't have a photo in this talk, but if you're curious, you can Google purple glove syndrome and you'll see examples of what can happen if you have an interstitial IV from phenytoin infusion. It can be quite nasty. And so that's a reason why, for medical legal reasons, in the US, phenytoin has fallen out of favor. Phosphenotoin is more expensive and it has to be refrigerated. So it's a little less convenient. You can't keep it on the code card compared to phenytoin. What about midazolam? So midazolams are a common third-line drug for treatment of refractory seizures, and it's given as an infusion. It's an ultra short-acting benzodiazepine. And I think it's important when you're using midazolam to be very clear what you're treating. Treating clinical seizures, treating electrographic seizures, or both. My recommendation would be to treat both clinical and electrographic seizures. And then establish how aggressive you're going to be. Do you want to abolish all seizures? Are are you going to tolerate infrequent short seizures? Initially, we try to achieve seizure freedom, but if we can't achieve seizure freedom without significant side effects, we may begin to tolerate short, infrequent seizures. The important thing with midazolam is that you need to give a bolus and then start an infusion. And as you titrate up, you want to keep giving a bolus every time you increase the infusion rate. So you'll see usually we increase by 2 mics per kilo per minute to a maximum of 24. But each time you go up, you give a little bolus. Otherwise, you're not going to achieve your steady state serum levels very quickly. Okay, so let's go back to our video clips and talk a little bit about whether things were seizures or not seizures. And I don't know, Cecilia, can we do a vote? Can we do a vote using using Zoom? Just people raise their hands?
You could raise your hands.
Yeah, let's do a hand raise. I have you here in gallery view. I'm gonna set it up so I can see everyone. Okay, looks like we have about, let's see, 1, 2, 3, 4,
21.
21 people. Okay, you all know how to raise your hands, I hope. So we're gonna do some voting here. Okay, we're gonna make this a little interactive, and you tell me if you think this is a seizure. So you saw this video before, and what I'd like you to practice is actually describing the event. So imagine you were at the bedside, you were witnessing this event. It's a short event, so by the time you call someone to the bedside, it's gone, it's finished, and so you have to describe it. Okay, so using the appropriate language is really important to communicate what you're seeing. Okay, so let's practice using language that will communicate effectively. So describe the event. Is it a seizure? Is it not? If so, what kind of seizure? So here's our
So
same.
just before you begin, we're just going to show them, because some people don't know how to vote, but you might see a little reactions sort of icon at the bottom of your screen, in which case when you click on it, you'll see clapping the hands or a thumbs up, a heart, and 2 faces. So what do you want them to do? Clap their hands? Yeah, maybe do a practice.
Okay, raise your hand.
Irina said it's under more. You guys might see it under more. Okay, there you go.
Let's see here.
So if you don't see reactions, then look for the more button.
Some people have it. In fact, I don't think I can. I don't know if I can. I don't think I can raise my hand while I'm sharing my screen. Actually.
No, you probably can't, and I can't either.
Okay, perfect. Okay, so we see some thumbs up. Excellent. Okay. I see some different colored hands too. That's good.
There we go.
All right. So let's play the video again. Oh, it says, oh, there we go. Okay, so if anyone feels would like to give it a try, just describe what you see, and use whatever language you would use to describe it to a colleague. Okay, so obviously within the same room together would be a little bit easier. But is there anyone who would like to try? Carlos, I see a heart. Would you like to try?
Is it a normal movement?
Is it a normal movement?
Yeah.
Well, maybe. It may be, it may not be, but how would you describe it? If you had to tell someone what you just saw, what you just witnessed, what would you describe it?
Following the breath, baby is moving the legs.
Mhm.
So.
And is it one leg or both legs?
Both legs moving in the same direction. So.
So I'm not sure how well this is coming through because of technology. But what I'm seeing is a rhythmic movement of the right foot. Some people might describe it as a jerking movement. I think if we classified this, if we thought it might be a seizure, which it may or may not be, the type of movement I would describe it as is a clonic movement, okay? Which essentially is a fancy word for a jerking movement, okay? And it's rhythmic. It's about 1 jerk per second. Just play it again so you can watch it, okay? See, jerk, jerk, jerk. And it's mostly in that right foot. And it lasts maybe 5 or 10 seconds. There's a little movement there in the left foot as well, but I'm not sure. It's certainly not as rhythmic as the movement in the right foot. So let's take a vote. How many of you think that was a seizure? Raise your hand. Okay, and how many think it wasn't a seizure? All right, and I assume the rest of you are undecided, or maybe you're no longer listening to the talk. Okay, so we're kind of evenly split, at least among the people who are willing to commit. So let's take a look at the EEG, okay? So I'm going to orient you to what an EEG looks like. So it looks like a bunch of squiggly lines to those of you who aren't used to looking at EEGs. First of all, the red lines are 1 second apart. So on this page, we have about 10 seconds of EEG. And at the bottom, we can see what you might recognize as an ECG tracing, okay? So this is your classic QRS complex. We usually include a single channel of ECG. And then we have some other electrodes, the respiratory movements. So this isn't picking up too well, but sometimes when we try to get a little strain gauge around the chest so we can measure the respiratory movements. Sometimes we put an electrode on the chin to measure EMG activity, so muscle activity in the chin. And all the odd numbers are on the left side, so the top 8 channels are left and the next 8 channels are on the right, and these 2 are right in the middle of the head. And sometimes you'll see color coding, so red is right, usually on an EEG. And the letters here correspond to different regions of the brain. Oops, different regions of the brain. So F is the frontal region, C is the central region, P is the parietal region, O is the occipital head region. So what we can see here is something different right around here. You can see there's this rhythmic activity, okay, which is mostly right here and maybe here as well. And this is the C3 or left central head region. And this is at the top of the head, which is right next to this. Even though they're far apart, they're close together on the head. We see this bit of a rhythmic activity. So when we see rhythmic activity in the brain, we get worried. We like to see rhythmic activity down here on the heart. We don't like to see rhythmic activity in the brain. And if we look at the next page, you can see how that rhythmic activity is starting to get a little higher in amplitude. And it's starting to spread a little bit to the other side, okay? And you can see this characteristic spike and wave pattern, spike and wave, spike and wave. It actually looks a little bit like a QRS complex, doesn't it? Well, we don't like to see QRS complexes coming from the brain. First of all, we don't call them QRS complexes, we call them spike and wave. And you'll notice that at this point in time, somebody has typed in clonus of the right foot. So this corresponds to that movement that you saw. And you can see there is abnormal rhythmic activity coming from the left central part of the brain, which is where you would expect it because that part of the brain controls the right side of the body. If you look at the frequency of these spikes, it is about just less than 1 per second, or a little bit faster than 1 per second. So here's one, here's another, here's another. So between 1 and 2 of these jerks per second. So that fits. So this child had focal clonic seizures of the right foot caused by a left hemispheric stroke. Okay, let's look at our next example of the neonate. Here it says 4 days old. I think the other example I had said 1 month old. Doesn't really matter. Describe the event. Is this a seizure? If so, what kind? And how would you test your theory? So here's our same video. Here, now the baby's all of a sudden 1 month instead of 4 days. So before, I heard someone describe this as abstinence or jittery movement. And that's a common description that I've heard. And we talked about how suppressing it could be helpful. If you can suppress the movements, they're less likely to represent seizures. And I think if you, not the best example, but I think you know, if you look at it carefully, it does look like it is at least, you know, suppressible for a short period of time. And it's bilateral, so both arms are involved. We don't know if the rest of the body's involved because it's covered up. And it's a much different movement from what we saw in the other example, right? It's much faster. It's less of a jerking movement. It's more of a shaking movement, more of a tremor, a tremulous movement. And so let's take a vote again. How many of you think the movement that we're seeing here is caused by a seizure? Raise your hand. All right. And how many of you think it's not caused by a seizure? Okay, a few more. Let's take a look at the video. Let's take a look at the EEG. Okay, so same idea. EEG is about 15 seconds or so per page. Here's your ECG tracing. Okay, and here is the event. Again, it's helpfully annotated by someone at the bedside who typed in arm and leg clonus, or left hand and arm clonus. I think it was actually more bilateral on the video at least. And you can see there is a change on the EEG. There's this really fast activity, okay, which is more on the left side. Actually, it's bilateral, left temporal and right temporal. And this is actually not due to brain activity. It's due to muscle contraction. You've got muscles right here, temporalis muscle. If you feel them, you can bite down. You can feel this is a big muscle. And when you tense up, which is what this baby was doing, those muscles contract and you actually pick up the EMG signal from those muscles. And that's what we're seeing here. It's that very, very kind of irregular, fast activity. The rest of the EEG looks fine. So this is not a seizure. I think based on the phenomenology, based on what it looks like, based on the context, it is likely this jitteriness due to abstinence. And it's a common clinical presentation upon weaning of opioid medications, which was the case here. So good job to those of you who were skeptical that this was a seizure, but it's very hard to know for sure without the EEG. Jitteriness and abstinence syndrome. So let's look at the last example here, a 2-month-old. Just describe the event again. Is it a seizure? If so, what kind? You'll remember the video. I'm going to fast forward a little bit so you can see the characteristic. The head moves out of the way. You'll see the characteristic rhythmic jerking again of the right shoulder. I would describe this again as a clonic movement. So a rhythmic jerking of one particular body part, in this case, the right shoulder. So let's take another vote. How many people think this is a seizure? Raise your hand. Okay. Many of you do. And who thinks it's not a seizure? Nobody. Everyone's convinced. Okay, let's look at the EEG. So first of all, let's think about if it's plausible. So this is the actually illustration of where different parts of the body are represented on the brain. So the motor homunculus, we call it. Homunculus means little person in Latin. And so where is our shoulder area? It's right here, okay? So this is a coronal section of the brain. So this is the top of the brain and this is the side of the brain. It's kind of a slice, vertical slice. And you can see the shoulder is right up here near the top of the central head region, base is here down the side, etc. So we would expect to see something in here on the EEG. And here's what our EEG showed. So again, we've got our nice ECG tracing here for reference. These first 8 channels are on the left, the next 8 channels are the right. These are in the middle of the brain. So at first glance, not much exciting. There's a couple of little movements here. These are actually caused by blinks of the eye, but nothing big in terms of a spike and wave activity like I showed you before. But here's the next page. Whoops. Here's the next page. You start to see something a little rhythmic here, okay? And a little bit of a spike emerging, okay? Whereas this is again in the left central head region. So opposite side of where the movement abnormality was. So that actually fits because the left side of the brain controls the right side of the body. And now it's evolving again in frequency, amplitude, and somebody pressed this button. So some of you may be familiar with the EEG machines. They have a little push button. And when you push that button, it puts a mark on the screen that says patient event. But we don't know what the patient event was. So it's very helpful actually to type a few words as well to let us know why you were pressing the button. And here we have the same activity. It's very prolonged actually. It's still remaining quite focal there in the left central head region, and then it kind of peters out and goes away. So this was a focal clonic seizure of the right shoulder. And in this patient, the MRI showed a left hemispheric stroke. So good job, everyone. Most of you got that one, you guessed correctly. Okay, in the last 5 minutes or so, I just want to tell you a bit about cerebral function monitoring or amplitude integrated EEG. How many of you have heard of CFM or AEG? Raise your hand. Okay, looks like not too many of you. So this is a technique that's actually starting to, I see, okay, a couple of you, great. This was an EEG-based brain monitoring device developed actually back in the 60s to measure depth of anesthesia during adult cardiac surgery. And then it was actually introduced into the neonatal ICU in the 70s and 80s, and is now in wide use in neonatal ICUs throughout North America and Europe. This was one of the initial devices, which was an analog-based device. And this is a more recent device. And it basically is a simplified EEG. So usually we use 4 electrodes, okay, on the 2 on the left and 2 on the right. Initially, people were using just 3 electrodes across the front of the head like this. And the amplitude integrated EEG display looks something like this. So on the top, we have the amplitude integrated EEG, which is a compressed EEG. You'll notice the scale here is 3 hours on the screen. And then usually on the bottom, you have the raw EEG tracing, which is again 10 or 15 seconds per screen. And you can click on the amplitude integrated EEG and you'll see the underlying raw EEG. So it's always based on the raw EEG. It's a processed raw EEG, a compressed raw EEG. The nice thing about it though is it gives you a really nice overview of what's been going on for the last few hours. And it turns out that seizures stand out from the background of EEG activity and they can be visualized pretty easily on the amplitude integrated EEG. So here's an example of a patient. I'm going to show you some more examples. This is a patient with repetitive seizures. Each one of these unusual elevations in the lower and upper margin of the tracing. So this is called the lower margin. This is called the upper margin. You'll notice both of them are displaced upwards like this. You get this kind of a hump. And if you place your cursor on here, you'll notice this unusual spike and wave pattern. And that's very characteristic for seizures, as you've seen now on the raw EEG. And here's what happens when you have status epilepticus or very frequent seizures. You see a pattern like this, which some people describe as a sawtooth pattern. It looks a little bit looks a bit like the teeth on a bandsaw or a handsaw. And when you give midazolam, you can see the effect on the EEG. You suppress the EEG background, and you see this drop in the lower margin, and the seizures go away for a while, but then they start to come back. So what's the pros and cons of this technology? So the nice thing about amplitude integrated EEG is it can be readily available, and it's put on by bedside caregivers. So you don't need an EEG technologist to come down to the unit to put it on. And when you look at the amplitude integrated EEG, there are ways of classifying the background activity of the brain. And that is it's just as accurate as a raw EEG at classifying the background activity, which can be very good, helpful for prognosis. But for seizure detection, I've shown you some nice examples of seizures, and sometimes they are that clear. But it's really a suboptimal tool compared to conventional EEG for a couple of reasons. First of all, it's not that sensitive because you only have 2 or 4 electrodes, and the seizures could be coming from other parts of the brain and you won't pick them up. So that's a problem. You also will miss short seizures because you've compressed the EEG down to 3 hours on the screen. So if you have a 30-second seizure or a 1-minute seizure, it'll hardly be visible on that little display. The other challenge is that it's often hard to distinguish seizures from other artifacts. So sometimes, the ECG signal, as I mentioned, can get picked up on the brain because the ECG is so much higher in amplitude than the brain waves. And without the video, most of these devices don't have a video and they only have 1 or 2 channels. It can be really tricky to distinguish the rhythmic waveform of an ECG from the rhythmic waveform of a seizure. So in the bottom line, I think it is a useful tool as long as you recognize its limitations. Sometimes you can identify a child or a baby that's having seizures, but I think it's hard to know how many seizures they're having. And once you've started escalating therapy, I think you need to get a real EEG or a conventional EEG to really guide your therapy. If you guide your therapy purely based on the amplitude integrated EEG, you could get into trouble. So that's my last slide. Thank you for your attention. I'm glad we were able to do a bit of interactivity despite it being a virtual format. And if anyone has any questions, please speak up.
Some comment. Well, I guess you can see the comments too.
I can't see the comments. Hold
Oh,
on.
okay.
Let me just
Well,
see
this was interesting session.
Let's see if I can pull them up. Oh, no.
Congratulations. Thank you. They loved it.
Good. Where's the chat? Here's the chat. Very good. Congratulations. Thank you. Well, I'm glad you enjoyed it. I hope it was useful and practical. And you'll think a little more about the brain and the interaction between the heart and the brain. The heart really only exists to keep the brain going, right? That's what we think as neurologists. So it's important to keep the heart going, though.
Yeah. Thank you.
All right. Thanks very much for your time, and good luck with the rest of the course. And stay safe.
Thank you.
Okay.
So have a great weekend, everyone. And we will have your exam marks for next Monday.
Thank you.
Okay. If people think it's beneficial, I might just retake my session. There was a little bit more at the end, and just put it in the folder. And if people want to look at it, they can. And if they've had more than enough of pacemakers, that's fine too.
Okay. Thank you.
Okay.
Regarding videos, ma'am, we didn't receive previous class videos.
Yeah, so that you're right, there are a few missing. Now there's 2 that we need to retape. So the one that is with Oshri Zowlin, that's the, we're just going straightly with Zoom now because the system here just kept shutting down. Some of you will remember being on that day, and it must have shut down like 6 times during his talk. So after November 23rd, he's going to retape that one. He's just really busy right now. But I will put the slides. I think I did put the slides there, but not the video. There's one from Seth Gray, also on T3. He didn't want me to tape it that day. And he didn't want me to post the slides either, just because it has patient, I mean, there were no names or identifiers on it, but he wants to just do a modified version to post and to do the video. So I think I persuaded him to do it for this weekend. So hopefully we'll be able to upload that on Monday. And there are a few Dr. Chasen's. It looks like I must have a video there somewhere, so I'll go back and look for it. And there was one more, the pharmacology presentation. I will upload that as well. But thank you for those who are sending me an email here and there to say that something or other is missing, in which case we'll try and get it up if I can. Does that sound fair?
Sounds good.
Okay. Have a good week.